So what I'm going to do, this is going to be a little bit different because it's a much more practical lecture on Raynaud phenomenon, to discuss some of the causes, some of the practical approaches that we need to treat this condition, which obviously can occur in the context of uncommon or rare diseases like systemic sclerosis, but is also a very common problem for patients who may have no other autoimmune rheumatic disease. So Raynaud's phenomenon was first described by Maurice Raynaud. I think he described it as a medical student when he was doing his doctoral thesis. And he described a series of patients that had very severe digital ischemia and gangrene. And there's been a lot of discussion over the years about whether these patients that he described, and that obviously led to the coining of the term Raynaud phenomenon, would be the sort of patients that we would actually label as Raynaud's phenomenon in our modern clinical practice, because clearly if they had gangrene, this must be secondary Raynaud's phenomenon, and it does seem quite possible that they might have had another related vascular problem such as a vasculitis. But one of the comments that that Raynaud made was that in these patients, there was often a acrocyanosis and a changing in the colors of the fingertips. And I think that what he was really identifying was the physiological vasomotor changes that occur in the peripheral circulation that underlie what we would label as Raynaud's phenomenon, and that are present really in any form of peripheral vasculopathy. So here you can see someone who's really showing me just the acrocyanotic phase of Raynaud's phenomenon. Those of you who have good vision might see that there are just one or two small mat-like telangiectasis on the fingertips. So this patient actually has mild limited cutaneous systemic sclerosis with a secondary Raynaud's. But many patients describe color changes of blanching, cyanosis, and then suffusion, this triphasic color change that we would recognize as Raynaud's. And it is a clinical diagnosis. And to be true Raynaud's phenomenon, this has to be an episodic change. So patients have to have defined or discrete attacks, and typically they will be prompted or provoked by cold or emotional stress. And what we notice when our patients describe this to us is that it's often a change in temperature, and it's often a change in core temperature that triggers the attack. So this is very much a sort of centrally induced vasospasm triggering Raynaud's. It tends to be much commoner in women than men, and in fact up to 1 in 10 otherwise healthy women can have some symptoms of Raynaud's or can demonstrate features of Raynaud's if you do a provocation test. Another very common symptom is paresthesia or numbness, relating just to sort of, I think, the impact of the loss of blood supply to the sensory nerves and the sensory nerves in the fingertips. So when we're trying to diagnose Raynaud's, it is important to take a good history, first of all, and there are a number of things in the history that can help you to discriminate whether a patient might be likely to have primary or secondary Raynaud's. We would always ask whether a patient might have a family history of Raynaud's phenomenon, because primary Raynaud's particularly tends to run in the family. Particularly in female relatives, you are reassured, if you like, when you hear that a patient has a number of people in the family with the same symptoms. The age of onset is quite relevant, and again, primary Raynaud's tends to start in the teenage years or as a young adult. We'd always take a history about whether there might be complications of digital vasculopathy, ulceration, or definite skin changes, because again, this is much more in keeping with a secondary Raynaud's phenomenon. And we would always ask about things that might be relevant that could be provoking Raynaud's, particularly whether a patient might be a smoker and whether they might be on any medications such as beta blockers or other treatments that might be provoking Raynaud's attacks. You can sometimes ask a patient just to look at color charts, and we have standard color charts available to sort of describe the color changes that they see. And you can do a formal cold challenge to get a more objective measure of cold-induced changes in the peripheral circulation using infrared thermography, plethysmography, laser Doppler flowmetry, and even portable radiometry that measures more directly the temperature changes in the fingers. It is important to try and really make the fundamental diagnosis, that is whether a patient has primary or isolated Raynaud's phenomenon that is a nuisance but not associated with risk of progression to a connective tissue disease, or whether they might have a secondary Raynaud's phenomenon due to a connective tissue disease or due to one of these other causes that I've listed here. So we see patients that have occlusive vascular disease that might manifest as symptoms of Raynaud's, and that comes back really to those original cases described by Maurice Raynaud, because even if you have a vasculitis or an embolic problem or macrovascular disease, you will often have symptoms that are worsened by change in temperature or by stress, because if you superimpose physiological vasospasm on these other vascular problems, you will have increased symptoms. So it's important to bear in mind that a patient may have occlusive vascular disease. We sometimes see vascular damage related to vibration, the so-called vibration white finger. So this is really vibrating machine tools triggering vasospasm, but the pathology or the mechanism being quite similar to Raynaud's. We see some patients who have neurovascular compression, the traditional thoracic outlet syndrome. So this might be related, for instance, to the presence of a cervical rib or an aberrant band of connective tissue, perhaps linked to the first rib, leading to either neural or vascular compression. The clue here is that very often this is very predominantly an upper limb problem and may well be an asymmetric problem, and the patient may describe their Raynaud's symptoms as being positional or changing according to their upper limb position. Drugs and toxins can, of course, induce vasospasm. I've talked about beta blockers, various drugs that might be used, in particularly, of course, recreational drugs and sympathomimetics can induce Raynaud's attacks. And then, of course, there are those important hematological causes that don't necessarily cause Raynaud's, but it may be more acrocyanosis, so cold agglutinin disease, cryoglobulinemia, paraproteinemia with hyperviscosity. So these patients may present with acrocyanosis rather than clear Raynaud's attacks, but again, an important differential diagnosis. And this is why when we're investigating a patient with Raynaud phenomenon, you do need to be quite comprehensive. And again, we would emphasize the importance of doing a really comprehensive screen for relevant abnormalities at the initial presentation, because what you really want to do is identify whether a patient might have an additional associated medical problem and whether this might be primary or secondary Raynaud. So I've really just listed the very standard tests that we would do, the blood tests, looking for a hematological cause, looking for an associated potential biochemical cause. An immunological screen would always include an autoantibody screen, but also looking for evidence of other autoimmune rheumatic conditions. We would always do a baseline chest X-ray. We may do a neck X-ray or imaging of the thoracic outlet by CT or MRI, particularly if we're thinking that this might be a compression syndrome. And I don't think you can really fully exclude those conditions without some more formal cross-sectional imaging. And then we come to the sort of vascular approaches that we have. And it's very important to perform microvascular diagnostic tests, I think, in assessing your patients, particularly those who might have secondary Raynaud's phenomenon. So we can formally assess the attacks, and there are various ways of doing that as summarized here. So there is a symptomatic grading, and in simple terms, generally you can grade your severity of Raynaud's as grade 1, grade 2, or grade 3, and operationally this often translates into sort of monophasic, biphasic, or triphasic Raynaud's. If you have a absolutely clear triphasic Raynaud's phenomenon, this would be graded as a grade 3. We have a number of patient-reported outcomes to more formally assess the impact of Raynaud's on a patient's quality of life or function. These are really things that we use much more in clinical trials, but the Raynaud condition score has emerged so far as the most validated measure. This is essentially a clinical impact score, where you can see here, this is the sort of schematic, that diary that the patient would fill in. It's a Likert scale here. You can see with the patient grading how much impact the Raynaud has had on their function today, and really this gives you a semi-quantitative measure from 0 to 10. So that's been used in clinical trials, but is really not probably not sufficiently sensitive to really be a robust tool, and there have been attempts to really get more meaningful measures, and one that is now under development is the ASRAC tool, the assessment of scleroderma associated Raynaud's phenomenon, specifically designed for patients with scleroderma and Raynaud's, and in clinical development at the moment, and hopefully will give us a tool that we can use at least in our systemic sclerosis patients. And then we come to the more objective techniques that I've talked about, infrared thermography shown here in a patient that has slow recovery after a standard cold challenge. And I'd also like to just highlight that, of course, you can assess the complications of Raynaud's, such as digital ulceration, and I'll talk about that in a little bit more detail in later slides. But if we just stick first of all to isolated Raynaud's phenomenon, you can see here the frequency that we see Raynaud's phenomenon in the different autoimmune rheumatic diseases. So 95% of patients with systemic sclerosis will have Raynaud's phenomenon, and that's why it's an important component of the classification criteria for Raynaud, for systemic sclerosis, and you get 3 of the 9 required points towards a diagnosis of systemic sclerosis just by having confirmed Raynaud's phenomenon. Mixed connective tissue disease, also very high frequency. Lupus maybe a little bit less, and perhaps less common in patients with pure idiopathic inflammatory myopathy. Once you get down to diseases such as rheumatoid arthritis, really there's some debate as to whether this is truly really associated with Raynaud's phenomenon, because the frequency in a female predominant disease is not that different from the frequency of Raynaud's in the otherwise healthy population. But the thing about Raynaud's is that it is really a microvascular pathology, but it really is perhaps a first stage of the vasculopathy that can occur in any of these autoimmune rheumatic diseases. And I just highlighted that here, that it really is the sometimes the first sign that we have that the patient is going to potentially go on and develop a more significant vasculopathy later. So I've just highlighted that here, that we do see patients with vasospasm. Here you can see the measurement of Raynaud's phenomenon using the standard cold challenge. So a patient has their fingers immersed in cold water at 15 degrees in a gloved hand for 1 minute, and then you measure over 10 minutes the recovery after that cold challenge. And I'll show you in a moment how that is in a normal patient and how that is in a patient with secondary Raynaud's phenomenon. So Raynaud's is an important component, but also in our patients with systemic sclerosis and connective tissue disease, we're seeing other important vasculopathies, as you can see. So Raynaud's is an important component, but is something that we need to see as part of a systemic vascular disease. So we have a primary Raynaud's clinic in our hospital. It was featured in our local press when we sort of got this going, and it's run by one of our very talented specialist nurses and a vascular technician, Dr. Howell, who spent his whole professional life doing microvascular diagnostic studies and is a real expert at doing that. And I'd just like to show over the next few slides really some of the information that we've learned from having this dedicated Raynaud's clinic. So I've talked about the microvascular diagnostics, and this standard approach using thermography is a very good way to quantitate the impact of Raynaud's phenomenon. So what you can see here is that you first of all acclimatize the patient to a warm room at 23 degrees. So there's a temperature controlled room. They're acclimatized for at least 15 minutes. Then they have a 1 minute cold challenge. And then you take every minute an image to see how they recover. And what you can see is that a patient who doesn't have Raynaud's phenomenon has a very good recovery. By 10 minutes, they've really return to baseline. And in fact, in a normal patient, they will often have a slight hyperemia, so their skin temperature will be slightly above what it was prior to the cold challenge. But in patients who've got Raynaud's phenomenon, you can see a very different recovery pattern. And what's clearly important is that those patients that have secondary Raynaud's phenomenon with associated connective tissue disease have almost no recovery over 10 minutes. And this is almost only because they may have very severe vasospasm, or they may have structural changes to the blood vessels that mean that recovery is very much attenuated. So a very important difference between primary Raynaud's phenomenon and those that have secondary Raynaud's with a connective tissue disease. So we can get some discrimination just from those infrared thermography studies, but it's the microvascular diagnostic value of nail fold capillaroscopy that's particularly important, and particularly when you combine this with the autoantibody screening in our patients. So a patient with a positive antibody and abnormal nail fold capillaries will be at much increased risk of developing a connective tissue disease in the future, even if they haven't got a connective tissue disease when they attend to the Raynaud's clinic. So here you can see a very nice photograph showing very normal capillaries, high density of capillaries in the nail fold, normal diameter and a normal capillary density. Here you can see patterns that associate with systemic sclerosis, early stage disease where we see an increase in diameter of the capillaries, but not necessarily a reduction in density, and then a reduced capillary number. So you get capillary dropout, but more dilatation of the capillaries in this active stage of disease. And then later, a much more disordered pattern with really distortion of the capillaries, a much reduced capillary density, and damaged vessels leading to hemorrhage in these patients. So what was very nicely shown in a study that came out of Montreal a few years ago now was that if you have the scleroderma pattern of capillaries and an antibody, even if you don't have clinical features of systemic sclerosis, you have an enormously high chance of developing systemic sclerosis during your follow-up period. 80% in this study of patients, when they were followed for up to 10 years, ultimately developed systemic sclerosis. So it is very important to use all of this material to differentiate those patients who have primary Raynaud's, so female predominant patients with an onset of Raynaud's of less than 20 years, a positive family history, normal capillaries, and a negative ANA without any other clinical features of connective tissue disease. This is an important group to identify because these patients will just need symptomatic management and will have a very good long-term prognosis, as opposed to those patients with connective tissue disease associated Raynaud's. As you can see, the suspicious features really that we see that would lead us to really want to watch those patients very vigilantly and potentially transfer them for formal connective tissue disease monitoring and follow-up. And our Raynaud's clinic has also given us an opportunity to also see, just like they did in Montreal, whether we can predict which patients are likely to progress to connective tissue disease. So here are some follow-up data for our cohort, nearly 1,500 patient years of follow-up with an average follow-up of 5 years. And what you can see, and this is very important because it's not just the positive predictive value of those abnormalities, identifying those patients more likely to develop scleroderma or connective tissue disease, but in fact, in our clinical practice, we think the negative predictive value of having a negative antibody screen and normal nail fold capillary is perhaps even more important, because this allows us to confidently reassure the patients that they have primary Raynaud's disease and a very low risk of progression, as you can see here. So very few of our patients developed a new antibody, and even fewer if they had negative antibodies and normal capillaries at baseline, even with this large duration of long-term follow-up, very low rate of progression. So this is important because it means we can identify patients at very low risk of future progression. The other thing that was interesting when we looked at this was that, in fact, those patients that do progress to systemic sclerosis are probably more likely to progress to mild systemic sclerosis and to limited cutaneous disease, as you can see here. So in fact, it's those patients who have anti-sentinel antibodies or anti-NRNP antibodies that are more likely to progress to the disease. And those patients who have a high-risk antibody for severe diffuse scleroderma, such as anti-RNA polymerase, in fact, we see a shorter period to progression, but in fact, it reflects the fact that that long-term prodrome of Raynaud's phenomenon progressing to systemic sclerosis is more likely to be a precursor of milder mixed connective tissue disease or limited scleroderma. But Raynaud's, as I said, is part of the systemic vasculopathy of our patients. I really wanted to move on to talk a little bit about managing the digital vasculopathy of systemic sclerosis, because this is really what's troubling our patients. It's not just the Raynaud's phenomenon, but it's the complications of Raynaud's phenomenon, in particular digital ulcer disease. And this has been another area of progress over the last few years for our patients, because we've been able to learn from the progress, particularly in management of pulmonary hypertension, to better manage the vasculopathy of systemic sclerosis in the peripheral circulation. So all of the drugs that we use for pulmonary arterial hypertension, Denton, PDE5 inhibitors such as sildenafil or tadalafil, or prostacyclin, particularly intravenous prostacyclin, have also been found to be helpful both for Raynaud's phenomenon, but also for digital ulcer disease. And here you can see summarized the approaches that we use for systemic sclerosis associated severe Raynaud's and digital ulcers. And this was summarized in our best practice approach published a few years ago now, which was really published from the UK Scleroderma Study Group, the consortium of specialized centers treating scleroderma patients in the UK. And this summarizes our approach to Raynaud's in this situation. So of course, treating any associated pathologies, the standard approaches of lifestyle adjustment, avoiding cold, stopping smoking, perhaps considering complementary therapies such as vitamins and supplements. But if patients continue to have severe Raynaud's phenomenon, we would then move on to drug therapy with vasodilators. We would consider antiplatelet therapies, although we don't think that these are necessarily very effective. Particularly aspirin doesn't seem to make a big difference, at least in our practice, to the vascular symptoms. But again, we would move on to what we would consider advanced therapies in our more severe cases, and this would include intravenous prostanoids or increasingly the use of PDE5 inhibitors, particularly sildenafil, but also tadalafil, which we find to be very effective therapies. And in fact, for many of our patients are now replacing the use of intravenous iloprost, because it's a treatment that can be given long-term at home and of course does not require hospitalization. But we also recognize that it's not just Raynaud's phenomenon we need to manage the digital ulcer disease, and we also need to recognize that some of our patients will develop very severe critical digital ischemia and infarction of digits in systemic sclerosis. And this is where we think there is a role for antiplatelet therapy, but we would tend to use clopidogrel in this case, so a more aggressive antiplatelet strategy than low-dose aspirin. Here you can see the oral vasodilators that we use and the PDE5 inhibitors that we use together with the appropriate doses. So this is really all part of our standard approach to management of Raynaud's. And very often we find that if you combine drugs together at a lower dose, you can get a greater clinical benefit with a better side effect profile. But the main limit for vasodilator treatment in Raynaud's phenomenon is that often these patients have low systemic blood pressure already, and so they are very prone to the hypotension and vasodilator side effects associated particularly with calcium channel blockers and some of the other drugs that we use, such as angiotensin receptor blockers or fluoxetine, can be better because they have fewer side effects than the calcium channel blockers. But it is the combination of Raynaud's and structural vasculopathy that really leads to the more severe digital problems. And here you can see very nicely illustrated in an arteriogram of a patient with secondary Raynaud's phenomenon due to systemic sclerosis, leading to severe digital ischemia, to the trophic changes of the digits, and indeed to digital ulceration. And really, it's a reminder that digital vasculopathy is certainly not a benign complication. It's one, as I showed you in the previous lecture, is one of the complications that our patients with systemic sclerosis most complain about because of its enormous burden in terms of pain and because of the associated complications. And what we know is that if patients have ongoing or recurrent digital ulcer disease, they are much more prone to the very severe complications that are shown here of septic arthritis, of cellulitis, of osteomyelitis, and of severe digital gangrene that may require either surgical amputation or lead to autoamputation and loss of digits. And we do have licensed therapies for digital ulcer disease, and I highlight bosentan as the first oral therapy that was approved for digital ulcer disease, and it was approved on the basis of 2 positive clinical trials. But one of the conditions of approval by the European Medicines Agency for bosentan for digital ulcer disease was the establishment of a large observational prospective registry to really understand the burden of digital ulcer disease and systemic sclerosis. And this was the DUO registry, and I worked with colleagues Loic Guilvin, Thomas Krieg, and Marco Matucci-Cherenik to really lead a scientific agenda linked to this DUO registry to try and better understand how patients are being affected by digital ulcers, and again, whether, like with other aspects of scleroderma, like pulmonary hypertension, like lung fibrosis, we could start to stratify our patients into whether they had milder or more severe digital ulcer disease. And this does seem to be the case, because when we looked overall at the more than 4,000 patients recruited into this study, but in particular in those patients where we had a longitudinal follow-up over at least 2 years, you could identify these different groups of patients based on their history of digital ulcers, even despite having best practice treatment, including bosentan. And around 50% of these patients went on to bosentan, others were on other treatments for their digital ulcer disease. So what we were able to identify very clearly was that some patients had a single episode of digital ulcers, but then it never recurred. Standard treatment was obviously effective, and those patients didn't have recurrent disease. Then we saw a group of patients that did from time to time have digital ulcers, and we labeled these as having episodic digital ulcer disease, but for much of the time they were free of digital ulcers. And then we had this group of patients that were rarely free of digital ulcers, that we categorized as either having recurrent disease because they never went for more than 3 months without having an ulcer, or they always had a digital ulcer. And what was important was that this grouping of patients really very nicely predicted whether those patients developed those very severe complications of gangrene, amputation, severe infection requiring systemic antibiotics or hospitalization, or they required opiate level analgesia. So what I think we've learned really is that, again, as for other aspects of scleroderma, you can stratify your patients, and some of them will do quite well, but some will have much more severe ongoing chronic digital ulcer disease. And just as for pulmonary hypertension, we have benefited from the evidence base that's emerged. And so the RAPID trials were the first pivotal trials that led to the approval of bosentan by the EMA for digital ulcer disease. And this was based on a 30 to 50% reduction in new digital ulcers. So again, a little bit like nintedanib for lung fibrosis, these trials didn't show that they improved the established ulcers, but what they showed was that they reduced the number of new ulcers. It was a preventative strategy, but it was convincing enough to allow the patients to access this drug. It was an approved therapy, and here you can see how we have been using the drug in clinical practice. So here's a patient who had really severe ongoing digital ulcer disease, and they required regular hospitalizations for intravenous iloprost. And despite that, they still developed recurrent digital ulcers. This patient went on to bosentan, and you can see that, in fact, after 6 months of standard treatment, the ulcers had all healed. And in fact, they no longer needed to come into hospital for intravenous iloprost. So there's no doubt that for patients with very severe digital ulcer disease, these advanced therapies can really make a big impact on their outcome. And we have evidence base to support the other approaches that we use. So PDE5 inhibitors have been shown to reduce both Raynaud's attack frequency and also to improve digital ulcer disease. And here you can see some data from a study where we added sildenafil on top of intravenous iloprost, and when the patients went on to sildenafil, they had a significant improvement in their long-term benefit from thermography. And here are some data from the SEDUCE study from Eric Hatchula in Lille in France. So he led a very nice multi-center study that showed not only did sildenafil seem to have a beneficial effect in terms of the healing of digital ulcers and over time, but it seemed to be an additive benefit that was particularly seen in those patients who were also on bosentan. So again, pointing to the point that we, as in clinical practice, we can often combine drugs working with different mechanisms. But I wanted to also think about some of the other sort of innovative approaches, and just as we have been using surgical approaches to the treatment of systemic sclerosis with the lipotransfer approaches, we've also been using surgical approaches for Raynaud's phenomenon. So historically, we used to send some of our patients for a surgical digital sympathectomy. So this is a microvascular operation that really strips the adventitia from the digital arteries and from the arteries around the palmar arch. And what we noticed was that this could often give a durable benefit for patients with severe Raynaud's phenomenon and refractory digital ulceration. But it was quite an invasive surgical procedure. It took a while for the patients to heal because, of course, they had Raynaud's and poor peripheral circulation. And occasionally we saw very troublesome scarring, particularly in our patients with scleroderma, secondary Raynaud's. And it was a procedure you could only perform once. So although it did have a place in our most severe patients, it was not something that we could really apply to a large number of cases. So we were very intrigued by the idea that we might be able to do a less invasive approach to sympathectomy, if you like, a medical sympathectomy using botulinum toxin. So a nerve blocking approach using the same botulinum toxin that is used for neurological diseases to try and treat bladder spasm or involuntary movement disorders, and that of course is in widespread clinical use for cosmetic procedures. So something we're very confident about in terms of its safety profile, but something that at least in some cases had shown some benefit for patients for vasospasm in Raynaud's, to improve vasospasm and also pain. So the problem with the traditional approaches to botulinum toxin injection is that the traditional approach has been to use a palmar approach to try and reach the neurovascular bundles in the digits using a palmar injection approach, which is very painful because you're injecting through the thickened and sensitive palmar skin. And really, to do that effectively, you almost certainly need to do it with a general anesthetic. And so it's, again, not a particularly feasible approach. So what our plastic surgeons have been piloting is a dorsal approach, which is shown here, where you actually use ultrasound guidance to localize the neurovascular bundles, and you can then do your perineural injection of botulinum toxin from a dorsal approach under local anesthesia, and it can be done in the clinic or as a day case in a much less invasive way. So again, we've been trying to build up our experience with this. We've recently published our experience of 40 patients treated using this approach with 10 units of botulinum toxin given to each of the digits, as you can see here. So a total of 100 units per hand, dorsal route under local anesthetic. We've performed thermography at baseline at 15 minutes and also after a follow-up several weeks later. And what we were particularly interested to see was obviously whether there might be improvement in the Raynaud symptoms, and we did indeed see improvement. So here you can see the 6-week response in a patient receiving Botox, or 3 patients receiving Botox. The pre-treatment thermographic image showing really marked acral vasospasm, and there's substantial improvement in a baseline scan 6 weeks later. But more importantly, we wanted to make sure that we were improving upper limb function. And there was a concern here, of course, not that we just wanted to improve upper limb function and symptoms, but we also didn't want to make things worse, because of course there is a potential side effect of reducing grip strength if you are weakening the intrinsic muscles of the hand with this botulinum toxin injection. What we were able to show was, in fact, if anything, we saw improvement in the grip strength in the dominant and non-dominant hand after this procedure, suggesting that the improvement in the Raynaud symptoms was allowing the hand to be used more effectively, and that we certainly didn't see any evidence of muscle weakness as a side effect. And you can see here the visual analog pain score also significantly improving at 6 weeks and 12 weeks. So a durable beneficial effect. So we do think this again is a useful treatment. Our issue and problem at the moment really is capacity, in that clearly it does require a dedicated clinic, and Raynaud's phenomenon being so common in our patients, it's not something that we can at least at the moment make generally available. So we reserve it for our patients who are not responding adequately or cannot tolerate the more standard oral therapies or intravenous iloprost. But digital ulcer disease and vasculopathy in scleroderma does very much need a multidisciplinary approach, and I've highlighted that here. I've shown how we need specialist nurses to advise patients to run those dedicated Raynaud's clinic. We work closely with our dermatologists. We need hand therapists, pain specialists for our most severe patients, and we very much need to work with our surgical colleagues as well. I've shown you what can be achieved with plastic surgery and with Botox injection, and there are increasing experience of even microvascular reconstruction in some patients who've got very severe concurrent macrovascular disease. But it's not all about the sort of medical treatment. We also need to think about simple things, dressings, and other sort of local approaches. It's important to consider where the ulcer is occurring, because patients on the ulcer on the fingertip will need a different approach to those on the dorsum of the hand, where we're more concerned about protecting from trauma. We use our specialist nurses very much to advise us about the specialist dressings that are available, and it really has to be often an individualized approach to try and facilitate ulcer healing. So systemic medical treatment is only a part of the approach, and you need to use all of these approaches as well. But it is those patients that have severe microvascular and macrovascular disease that can be particularly challenging. I'll just share with you one example, one case history here. So this was a lady who had typical anti-sentinel antibody positive limited cutaneous systemic sclerosis. She had some mild interstitial lung fibrosis. She had typical gut symptoms. She also had really severe secondary Raynaud's and digital ulceration. And we treated this with losartan, with sildenafil, with iloprost, and with bosentan. And we were really frustrated because although the ulcers healed on many of her fingers, she was left with very severe digital ischemia and recurrent ulceration and secondary infection and really intractable pain just in these 2 digits of her left hand. We did lower limb Doppler angiology, upper and lower limb Doppler angiology to look for macrovascular disease. We didn't see any obvious evidence of severe vascular involvement where we might have expected to see it in the forearm, in the proximal palmar arch. So this was a little bit puzzling, but we felt that there was something more going on here. And in fact, we therefore went on to do more imaging with arteriography and with MR angiography. And what we were able to show was that in fact there was a severe proximal stenosis on the left side of at the origin of the left subclavian artery. So we were seeing normal Doppler angiology more distally, but there was this very severe and tight proximal stenosis. So she underwent an angioplasty here and in fact had a stent insertion, and there was gradual improvement. In fact, she then ultimately, although she of course lost some of the fingertip of these 2 digits, she actually had a good improvement and then was much better controlled just on standard medical therapy. So really an important reminder to always be thinking in patients with severe digital vascular disease, whether it's Raynaud's or ulceration, whether there might be a structural component. And I just wanted to finish with a condition that we see as an overlapping condition with Raynaud's phenomenon, and that is erythromelalgia. So erythromelalgia is a very challenging medical condition that was first described by a North American physician in 1878, and this was Mitchell. So he was a physician, and in fact, he'd already described various forms of complex regional pain syndrome. He was, if anything, more of a neurologist than a rheumatologist, but he identified this condition, which was a condition in which that pain, peripheral pain, was associated with erythema of the extremities, and the term erythromelalgia was coined. So painful red extremities. And in addition to having that sort of intense burning pain and coloring, a discoloration, patients often describe a paroxysmal hypothermia, and that their attacks of erythromelalgia are really triggered by increased body temperature or by exposure to increased temperature. So it really is very much the opposite of Raynaud's phenomenon. So warmth intensifies the discomfort, and if anything, low temperature often perhaps will give some relief. It can be a systemic problem, so it can affect any of the extremities. It's perhaps most typically seen in the lower limbs, but then when patients develop more severe problems, it becomes very much a systemic association. So just as we identify patients with Raynaud's phenomenon as potentially having isolated or primary Raynaud's, we see the same discrimination with erythromelalgia. So we identify those patients who maybe have secondary erythromelalgia, where there is an associated problem, and it may be a problem with the circulation, it may be a neuropathic problem. It can have a small fiber neuropathy associated with diabetes. It can be associated with microvascular disease, and in the lower limbs, sometimes with venous insufficiency. But the hematological cause that is most important is thrombocytosis. So increased platelet counts can very much be associated with new onset erythromelalgia. And in fact, it's very important to exclude that, because this is certainly a treatable cause, but also because, of course, thrombocytosis may be a presenting feature of a more significant hematological problem that requires specific treatment. So when a patient presents with erythromelalgia, we'll first of all very carefully undertake those investigations to look for a secondary cause, and then we will use simple measures, just as you might with Raynaud's phenomenon: stopping smoking, cooling fans, topical coolants, emollients can be useful. We try to advise our patients to avoid what some patients have been doing when they come to see us, which is immersing their feet often in cold or freezing water, because ultimately this can reinforce the vasodilatory complications and actually lead to a worsening of the symptom. And our approach really is to try and treat the different facets of the disease. So I've talked about the blood. So if we see thrombocytosis, of course, we will refer to the hematologist who may directly treat that problem. If we do see increased platelet counts, we'll also consider giving an antiplatelet drug such as aspirin or clopidogrel, and we'll also consider using fluoxetine, which can, or an SSRI, which can reduce platelet serotonin and can improve symptoms. We'll consider treating the neuropathic component with neuromodulators and really gabapentin, pregabalin, venlafaxine, any of the drugs we might use in a complex neuropathic pain patient we might also find benefit from. But it's those patients that have an associated vasospasm with their erythromelalgia. So some patients do have Raynaud's phenomenon, and the erythromelalgia is really the suffusion phase, the vasodilatory phase of a Raynaud's attack that's really triggering problems. These patients paradoxically can show improvement with a vasoconstrictor approach. So these are the drugs that we use in our routine practice. So aspirin as an antiplatelet agent, fluoxetine would commonly be used because these drugs don't have significant side effects in most patients. I think treating the neuropathic component in a patient with severe erythromelalgia is often essential, and gabapentin, pregabalin, venlafaxine can be considered. And then we would consider the vasospastic component. So rather disappointingly, beta blockers themselves are not that effective and often again can precipitate sometimes worsening erythromelalgia. Vasodilators, as I say, in a patient with associated Raynaud's can be helpful. Just occasionally, and particularly in patients who have familial or genetically determined erythromelalgia, which is associated with a specific genetic defect of the sodium channel, a gain of function mutation in one of the voltage-gated sodium channels, these patients can respond to drugs that reduce sodium channel activity. So patients can respond to, for instance, a systemic lignocaine infusions, which are given sometimes in our pain clinics. And oral mexilatine, an old-fashioned antiarrhythmic drug, can be used and beneficial in some of those patients, but that tends to be really in those patients with that very specific neurological cause. A practical treatment that we've found useful, because we were using it in our patients with secondary Raynaud's phenomenon, but seems to benefit some patients with very severe erythromelalgia, is in fact intravenous prostacyclin. So this can be challenging to give because patients may get symptoms of erythromelalgia worsen during the infusion because of its vasodilatory effect. But once you get over those side effects, over subsequent weeks, the patients often really show an improvement in their erythromelalgia. And we think this is because this is a drug that can really normalize endothelial and vascular function. So this is a treatment that we are using in our patients. We wrote up a series of 46 patients who developed significant severe erythromelalgia that were treated with intravenous prostacyclin, and around half of the patients demonstrated significant benefit. So it doesn't work for everyone, and we would only continue to use that treatment in patients who were benefiting. So I hope that that has been helpful just from a very practical approach of how we're approaching vasculopathy and microvasculopathy in scleroderma and Raynaud's phenomenon in all of its contexts. Raynaud's is very common, but it's important to stratify your patients and work out when the Raynaud's is part of a disease that may have additional clinical burden. It's very important to always look for concurrent structural vascular disease, whether this is structural vascular disease from a connective tissue disease or from a macrovascular disease in patients with severe Raynaud's. And I just wanted to highlight that erythromelalgia, rather paradoxically, is something that we see also in some of our patients with Raynaud's and can be particularly challenging. So again, I'd like to thank all of our team and my colleagues and collaborators, and again, very happy to take some questions. Thank you very much.